Glenn, do we have contact? I'm sorry. And I can't do it for him.
If you can hear us, Glenn, we can see that you've arrived virtually and you need to unmute.
Can you hear me now?
Yes, Glenn,
Great.
do we have you contact now?
Yes, I can hear you loud and clear.
Thank you. With that, we will call this meeting to order, July 28, 2022 of the Panhandle Health District. And I'm sorry for the brief delay, but I suppose on the next minutes, why our very capable secretary will have us starting a few minutes late. Okay, let's begin as we stand for the Pledge of Allegiance to the flag. I pledge allegiance to the flag of the United States of America and to the republic
for which it stands,
one nation,
under God.
indivisible, with liberty and justice for all. Thank you, and you may be seated. Our first item on the agenda now is the public comment session. Is there anyone here wishing to make public comment? If so, you are allotted 3 minutes for your comment. Anyone here wishing to make public comment? Okay. All right, second call and third call. And there is no public comment today. You have in your packet the consent agenda for today, the minutes of May 26. Any comment on the minutes of May 26? All right, there are the division reports. Trust you've had time to glance through the division reports. I find them very, very interesting. In the consent agenda today, there are a number, I think about 6 contracts. Is there one or more of these contracts you would like to pull for further question or discussion? Any comment then on any item on the consent agenda? There's also the the personnel policy, an update, and according to what I understand, it's virtually the same. It's just simply an update, and our director can make a brief comment as to what brief change there is. Don, you have the floor for a moment.
Thank you, Mr. Chairman. And if I may turn a few minutes over to our HR specialist, if that's okay with you, to Michelle, she'll give you a quick summary of the updates of that particular policy.
Mr. Chairman, so this is the overtime and hours of work policy that we updated. We updated mostly the on-call hours that our home health team is using. They have on-call hours as required by CMS. I'm not sure what that stands for, but we changed it from 8 hours each day on the weekend to 3, and from 3 hours to 1 hour on weekdays. So it was becoming excessive, the overtime. So we decided to make a change. So that's basically the major part of the change.
All right. So that would be it for the consent agenda. All in favor of approving the consent agenda indicate by saying aye.
Aye.
Opposed, no. And is so ordered. We have approved the consent agenda. Do you want someone to make the motion for that? I saw that in your eyes. Which one of you likely doctors would like to make the motion that we approve this consent agenda?
So moved.
Okay, we have the motion and second, and we have approved the consent agenda. Yes, we have one person left to make the second.
I just want to hear it.
Okay. As is the usual this time of year, we elect officers, a chair, a vice chair, and a trustee who is also then our member of the executive council. This is an action item. You can do this one at a time, or you can do it with one sweeping motion. What is your pleasure?
One sweeping motion.
Pardon?
One sweeping motion sounds lovely.
One
One motion.
One motion,
Make
yes,
it all happen.
yes. Is that your motion?
I'll
That's your,
second it.
okay, you'll second it. All right, got it. All right, we have a motion and a second that we retain the current officers for another year. All in favor, say aye.
Aye.
Opposed, no. And that is taken care of. And I assume, Glenn, that you approve of being the vice chair and trustee again?
Yeah, yes, I do. Thank you.
Thank you, thank you. Okay. Do we have some ballots for election of new board members?
Yes.
Okay, so with, by common consent, can we let you, and who's going to help you today? Oh, okay. We will turn the ballots over to you, and as time permits, we'll let you two ladies tally, and when you have them tallied, then you can turn them over to me, all right? So while that's being done, and we will vote on that after I receive the tally, let's move on to Jennifer, who's going to make an introduction for our program highlight and a monkeypox update. Jennifer, you have the floor.
Okay, Mr. Chairman and members of the board, it's my pleasure to introduce Jeff Weigel. He's our program manager for epidemiology here at the Health District. And he's got 20 years of medical experience as a paramedic, so he brings a wealth of knowledge and information to us. And I will turn the podium over to him to talk with you today about monkeypox.
Thank you. Welcome, Jeff. I don't know how many of you have met or haven't met. This is Jeff. You have the floor.
Thank you, Mr. Chairman, members of the board. I appreciate your time today to allow me to present on monkeypox. So the current cases that we have in this global emergency that was declared last week, I believe, globally, as of yesterday, there was 20,638 cases, 98% of those. So 20,311 were reported in countries that have not historically reported monkeypox in the past. We have a little over 4,600 cases as of yesterday in the United States. We have 2 confirmed cases in the state of Idaho. Those are both in Ada County, and they are not believed to be epidemiologically linked in any way. The history of monkeypox So it is an orthopox. It belongs to that genus, and it is a distant cousin to smallpox. So smallpox is part of the variola virus, and the monkeypox is part of the vaccinia virus. So they're not from the same lineage, direct lineage. And it was first discovered in 1958 in monkeys in Copenhagen. And the first known case of transmission to humans was in 1970, and that was in the Congo. There are two strains referred to as claves. There is the Congo Basin clave and the West African clave, and that is the majority. The West African clave is the vast majority of the strain of virus that is going around the world right now. This current outbreak is believed to have started back in May at a couple of rave nightclubs, one in Spain and one in Denmark. The transmission characteristics of this is that it is not easily transmitted as COVID-19. That's the big one. It has been traced to be followed as far as 6 generations. So it can be contacted by lesions, direct contact with the lesions themselves, with body fluids, respiratory droplets. So that is intimate face-to-face contact. Because this is a DNA virus, it has a higher molecular weight and will not travel quite as far. But it can live in materials such as bedding, porous materials for months. So that should be something that you should be aware of if you have kids that are jumping into bed with you and you haven't washed and you've been exposed at some point. Signs and symptoms are common, like with any viral infection: fever, headache, muscle aches and backache, swollen lymph nodes, chills, and general malaise or exhaustion. Something that's characteristic of this is that they will have the pimples or blisters that appear in unlikely places, face, palms of the hands, bottom of the feet, mucal linings such as the mouth, genital areas, and around the anus. This is what they look like and the progression of them. They often appear, the top left there, is they appear like a pimple. And they're generally not clustered in certain areas. They're spread out. But you'll see as it develops on that third picture, there is an umbilical-like depression in the center of it. That's a characteristic of monkeypox. This is often confused, especially with rashes on the hand, for secondary syphilis. So we are advising providers when they test to also test for syphilis at that time. And you see the progression of this. So from the first slide to the 6 generally takes 2 to 4 weeks to progress. Once it enters that 6th slide there, the last slide, it is not infectious at that point. And these are some pictures, generalized pictures of what it may look like. And you can see the spread out pattern of it, palms of the hands. So the mitigation strategies that are recommended at this time is, of course, washing hands and avoid close, intimate contact with somebody that you know has been possibly exposed. Caregivers are required to wear masks and a shield. Just recently they added that on, and gloves, and to launder your bedding and clothes and just normal wash with detergent on warm or hot. So the treatment for this is most of them just clear on their own. And the mortality rate from this is relatively low. It's at 3%. And they can use antivirals such as TPOXX, and that's recommended for those that have an increased susceptibility. So their immunosufficiency. So people with HIV, somebody who's gone through cancer treatment. Because it's a virus, of course, antibiotics cannot be used, but opportunistic bacterial infections, pathogens can take up residence in an open sore, of course. So vaccinations. So we have received from the CDC 40 doses. So that is 20 treatments. They're to be given at 28 days apart. And they are stored here. We have them here right now. If anybody in one of our outlying counties has a case that needs vaccination, that meets the qualifications for that, then we will have that run out to them to be vaccinated. They're expecting more vaccinations to be available by the end of the summer, the CDC is. Now, the smallpox vaccine can provide some protection for people born before 1980, and even some a little bit after that because of passive immunity. But as we all know, the vaccinations can wane over time. So these are the characteristics, or these are the requirements for, or the restrictions for vaccination for the vaccines that we have, because they're the amount that we have are so low. So there is a post-exposure prophylactics, PEP, and those are for individuals who have had exposure to those with a confirmed orthopox or monkeypox virus infection, and individuals who are aware that one of their sexual partners in the last 2 weeks has received a monkeypox diagnosis. Then there is the PrEP, which is pre-exposure prophylaxis, and that is for certain healthcare members and public health response teams that that the public health authorizes. And right now, that's the state of Idaho authorizes to be vaccinated for preparedness purposes. And then there is the expanded post-exposure prophylactics, and that should be like expanded demographic. So this is for people who have had sex with a person or report either of the following in the past 2 weeks, and that is group sex or sex with multiple partners, or 2, sex at a commercial sex venue in association with an event like a rave, a venue, or a defined geographic area where there's a large amount of monkeypox that has been discovered. Mr. Chairman, the board, any questions?
Thank you. Questions? Have any questions or comments?
Mr. Chairman, this is Glenn.
Yes, go ahead, Glenn.
I was just curious. I had heard there were only 2 confirmed mortalities in the U.S. Is that correct?
2 confirmed mortalities, did you ask?
2 confirmed mortalities?
Yes,
Is that
that-
correct?
That is correct, sir.
And this is
And those were in New York,
in New York?
yes.
Thank you.
Any other comments or
Those two
questions?
individuals have comorbidities.
That I do not know. I don't know if they had comorbidities or not. But I can find
And
out for you.
specifically, did they have, were they HIV positive?
That I do not know, but I know it was a situation of MSM.
Well, thank you, Jeff. Why don't we have you here front and center? There seems to be a little bit of rumbling about COVID here in the recent weeks. Do you have any comment? I know that's just off the cuff. What can you tell
Sure.
us there?
Sure. Yeah. So here regionally, it's pretty much, it mirrors what's going on nationally with cases going up. The new BA.5 variant occupies about 80% now of the variants that are across the United States. Cases are going down lately, which is good to know. And something that's characteristic with this virus or this variant is that it has less severity. So it's more transmissible, but it has less illness severity. So there's less hospitalizations than that we exposed to the previous Omicron variant in January and February.
Thank you.
You're welcome.
That comment?
What about the, how effective is the vaccine towards BA 4 and 5?
the vaccine, it's effective at not allowing death, at preventing death and severe hospitalization. This variant does have a way of working around the vaccinations and the boosters, but most people are asymptomatic from it, or they or they are not being hospitalized from it.
Are you at all familiar with ONS data, British data?
I am not, sir.
Okay, fair enough.
Anything else? Comments or questions? Jeff, appreciate your contribution to our meeting today. Thank you.
Mr. Chairman, members of the board, I appreciate your time.
And anything else that comes up, why, we'll be happy to hear from you at some future meeting.
Anytime. Thank you.
Thank you. Glenn, are you still within earshot of us?
Yes, I am. Can you hear me?
Yes, we can hear you fine. What do you have as far as the trustee report for us today?
The trustee report is that we are now chairing the trustee meetings, and I have got together with Don, and we will be putting together agendas probably for our first trustee meeting will be in September in conjunction with the county commissioners quarterly meeting. So that's what we're planning. That's all I have to report.
All right. And is there any discussion going on at all as far as IAB next June?
That will be an item on the agenda for our discussion.
Thank you. Thank you. Well, we'll be interested to hear how that turns out, Glenn. Thank you.
You bet.
Do you have, are you ready for, then we will go back to item number 6 on our agenda. Thank you, Tina. Okay, here's a report as far as our 2 board members. By the way, Dr. Fletcher, I promise when you come to your 3rd meeting with us, that you won't have to go through this election process the 3rd time in a row. All right. It looks like the number of votes cast is, there was 12 necessary for an election. A majority is 8. And Dr. Fletcher has received 12 and is elected to our board. And Glenn Bailey has received 12 and is also elected to our board again for, I believe it's a 5-year term. So congratulations, Glenn. Congratulations, Dr. Fletcher. And we're happy to have you on our board for at least another 5 years.
Thank you, sir.
Yes.
Thank you.
Yes, you are welcome. All right. Have that taken care of. Let's go to our finance report. And you can find this in your packet. And I believe it starts on about page 31, 32. You have the floor, ma'am.
you, Mr. Chairman, members of the board. We will start with, usually we start with our cash history. Today, I'd like to start with our budget to actual. We'll be reviewing the 12 months ended June 30th, our fiscal year 22. And our financial story stays the same. It's been consistent throughout fiscal year 22, but we'll do a final review. We'll start with revenues, and our licenses, permits, and fees, which is the environmental section, is under budget by $99,000. That was purely a budgeting issue. When we budgeted last year, we budgeted based on the volume that we had in fiscal year 21, and it was actually about $500,000 higher than this fiscal year. So that's related to last year's budget anticipation, what we anticipated to do for fiscal year 22. Home health, we've previously discussed. It is under budget by $322,000. We do have a plan in place for fiscal year 23. Health services over budget by $89,000. General support over budget by $93,000. Those are the death certificates that we process. And that's also a sign of our growing community, the number of death certificates that we're processing here. And this one we have highlighted frequently in our meetings. Our grants and contracts are under budget by $895,000. We've previously discussed that this is related to our staffing issues. We had trouble staffing. So if people are not working the programs, we're not billing the grants and contracts. The other thing that plays into this is the indirect rate. Our indirect rate pre-COVID was 39.5%. In fiscal year 22, it was 22.35%. So we were not billing as much indirect to these contracts. And again, if people aren't billing to the contracts, if they're not working the contracts, we're not billing also the indirect rate. Interest, as we all know, interest crashed. It dropped, not that it was high at the beginning of the year. So basically it was over budgeted. Rent, as we previously discussed, is some of the rental spaces that we're renting out to other agencies in the outlying offices. That was over budget by $1,200 due to the fact that we took on a new agency mid-fiscal year 22. And our other revenues are under budget by $15,000, and that is primarily related to donations. This county shows under budget by $312,000. What that is, that's a timing issue because we budget based on our county ask and our state ask going into a fiscal year. Because of House Bill 316, there's an additional component that was added to the counties, and we bill the counties based on their request on the federal year. So our last payment for fiscal year 22 will actually be billed this first quarter of fiscal year 23. So we should see after fiscal year 23, we shouldn't see a large variance like that. That's new as a result of 316 timing difference. So total personnel expenditures under budget, $316,000. Operating expense under budget, $279,000. Capital under budget, $86,000. Trustee benefits under budget by $52,000. Total under budget was $830,000. Our budget to actual deficit, our actual operating deficit was $998,000. If we adjust for the change in our accounts receivable, add in our beginning of year cash balance, it brings us back to the June 30th cash balance, which we'll look at in detail in the cash history report. Any questions on the budget to actual? No questions, then we will look at, did I just lose everybody? Thank you. Then we will look at, is it this one I want? On the right. The blue, I was looking for purple. Zoom meeting. Thank you. Thank you, Robert. So here we are on our cash history. As we just saw, we ended June with $3,935,000. This is a difference between prior year in June 2021. It's a decrease of $1,106,000. So our months in reserves currently is 3.47. If we back out our board committed funds and our program restricted funds, which total $860,000, we have 2.71 months in reserves. And just as a reminder, our board committed funds are for building maintenance, vehicles, IT, and we've been putting money aside for the 27th pay period. We're also accumulating interest for these funds that are invested in a separate account. So after we back those out again, our months in reserves, 2.71. I did a quick calculation, added that 800,000 that we were short in grants back into this. And if that is added back in, that brings us back to where we normally sit in normal years without COVID. We would be at 3.42 months in reserves if we had been on budget with our grants. So one of the action items that we have, and before I move to that, are there any questions specifically related to our cash history?
Well, only a comment. This right-hand column for the fiscal year 22, I just can't believe how fast that column fills up every year. Time marches on,
It does.
doesn't it? And then as far as the 2.71, that's within the ballpark of your comfort zone, right?
No,
Okay.
it's not.
All right,
and-
let's hear it.
Mr. Chairman, that's where I'm going next, is we have an action item on our agenda to move funds into board committed. What I would like to propose to you and the other board members is that we delay that until this fall, one of our next meetings. I personally am uncomfortable at 2.71. My comfort level is 3.3 months in reserves to 3.5 months in reserves. Let's settle in the middle at 3.25. I'm uncomfortable at 2.71 and moving any funds at this time. And I realize we could uncommit funds, but it was painful during COVID, and hopefully we don't go there again. But our funding is limited for a response effort at this point. And when funds were available, we were very slow to get reimbursed, and we relied heavily on our cash reserves during COVID. I personally don't want to go past 2.71. So I would ask that we possibly delay moving funds to the board committed categories.
Okay, could you, we can take care of that right now if you'd like. But what I want from you is to be quite specific now with how you want that motion worded so Daniil can get that down to your satisfaction.
I would suggest that the board make an action to delay, to revisit moving excess funds to board committed funds until the next meeting.
Now, next meeting, you're referring to September 22nd?
And then our next meeting after that is what, November?
I would have to look here, but
It's every other month.
I think, I think so. I just made a note of the next. Here we go. After November, the November meeting would be November 17.
I would move to revisit this at the November 17th meeting. And the reason I suggest that is that will give us a full quarter plus October, 4 months to see what our cash balance is.
All right. So the date now is on this motion is November 17.
Yes.
All right. And that, she would like that to be our motion. Is there a second? Who would like to make that motion?
Well, I'll make the motion, but then I have a question, but we'll do that
Yes.
during.
As soon as we have is there a second to the motion?
Hey, Mr. Chairman, this is Glenn. I would second the motion.
Okay, we have a second. Now, questions, Dr. Fletcher.
So what are the consequences of not making the delay?
I would say that there would not be any significant consequences. If we got to the point where we needed to move funds, if we needed the funds, if they were not available in our general funds, and we needed to look to, say, board committed funds, we would have to request the board, either by special meeting, or if it were not a regular meeting, to release those funds back into the general fund. It would require a board motion.
But if I hear you in between the lines, the likelihood is somewhat small, but still it would put you in a more comfortable position as far as handling our funds.
Yes, I really would prefer to stay at the 3 months in reserves or 3.25. The other thing that we haven't seen the impact yet is going into our new fiscal year, we haven't seen how our salary increases, how our new cash flow is going to look.
I love this when this part of a finance officer sneaks out. You say, well, she should be just totally objective in this, but it is really hard for a good finance officer to be totally objective. They become emotionally involved, and that means they care.
Mr. Chairman?
Yes, Don.
So Christine, help me to make sure we all understand this regarding the board committed funds. What you're suggesting is that would not increase until November 17. Is that what you're suggesting?
That this 2.7 would not increase?
Or where you have board committed funds of 514,931.
That is what I'm proposing. It stays. We make no additions
We
to
make
it
no
this
additions to that. And that's important because we do have some grant funding that could be coming to us that could possibly be board committed funds, things like the opioid settlement funds that will be coming to us. So we just want to make sure that we keep that where that is, and we can make decisions on that beginning November 17.
Okay, any other comments or questions? Does that help answer
Well, I
your?
could ask the flip question, what's the downside of not transferring the funds? I'm just trying to get a handle on pros and cons. I'm new to this, I really don't have a bigger perspective of.
Probably.
I understand the value of what you just said. You don't wanna miss the runway on the airport. I get that, and that's very wise of you. But what's the downside of not transferring?
I would say that there's no downside.
Yeah.
The funds, we have two funds. Three. We have our general fund where the money is readily accessible, such as equated to a checking account, but it's all held at the state treasurer's office. Then we have two LGIP, local government investment pool accounts. One is where we move any excess funds, and we can move that back and forth easily. And that's where we do put our excess funds from the general fund. Then the second LGIP account is an account where we have the board committed funds. That interest that you saw in our board committed funds here, that is the interest that it's earning. But we can't move funds out of that account unless it's board approved.
Yeah.
So we do have, the larger amount, this is what we currently have in our operating account. In our investment accounts, we have a total of 3.2 million, of which 500,000 of that is sitting in, plus the prior board committed funds, is sitting in a separate investment account. That's the one that we cannot move funds in and out of without your approval. So really, there is no downside other than if those funds are needed, we need board approval to access them.
So probably, now we're dealing in probablys here. When we get to November 22nd, we'll look back and say, we didn't need to make this motion after all. However.
Let's hope.
Yes.
Right.
Okay. So any other questions, concerns about this motion? Glenn, are you still with us?
Yes, Mr. Chairman, I'm still here.
Okay. We are going to vote on this motion. Are you all ready to vote? All in favor of this motion indicate by saying aye.
Aye.
Opposed, no. And the motion carries.
Thank you, Mr. Chairman.
Yes, so go ahead and continue.
So the last item on the agenda is the legislative audit. In December, we received the fiscal year 20 audit. It was completed and it had an unmodified opinion. So now we are looking at the fiscal year 21 audit. It is under audit currently. Auditors were here last week. They did their field work and they're currently back in Boise, continuing to do more analytics and review of our documentation. Supposedly, it's going well. I haven't had any questions that cause me concern, but we are only at midpoint in the audit process. And this audit has given me, knowing this audit was coming up, has caused me concern because of our COVID response and also in fiscal year 22. We had a lot of activity, but so far so good.
And we need to remind ourselves, we are being audited every year, which has its advantages over the districts who are only being audited once every 2 years.
Very much so. Very, very, very true, Mr. Chairman. And my peers in the other districts also share my sentiment that they also have concerns, primarily because of, and I've probably gone too far into the weeds, but primarily because of the COVID funding, because the guidance was constantly changing as it was coming out, or there was no guidance. So a lot of research has gone into researching the COVID funds.
And then also, on this 2-year bit, if they find a problem, then it's a problem that's already 2 years old. Okay, carry on.
If there are no further questions, this concludes my report, Mr. Chairman.
Thank you. Unless you have any other questions or comments, appreciate always your work. Couldn't run this place without you. Okay, we'll move on now to our director, Mr. Duffy. You have the floor.
Thank you, Mr. Chairman. Just a couple of items on the agenda and one I'm going to add as well. First of all, just that the district directors met in Boise a couple of weeks ago, and we meet periodically to try to come together on a few items. And there was 3 items that came up. One is food fees. There is going to attempt, the trustees are hoping to remove food fees from Idaho State Code. And currently in the food fees, there is one fee that we can charge throughout the state of Idaho. And there is no flexibility based on geography of what those fees might look like. And so the trustees, again, Mr. Bailey is the trustee that represents Panhandle Health District, are hoping that that will be removed from code, allowing health districts with, in essence, counties to decide the fees for food establishment inspection. So that was one item that was discussed. Also, we talked about the infrastructure grant, which is also on my agenda. That is an interesting grant in which the CDC has provided funding to improve infrastructure of public health departments. That is a significant grant that would be for Panhandle Health District around $390,000 a year for 5 years. However, much of those funds come from ARPA funding. And so we would need to have approval from the state legislature to use those funds. So that approval, if given, would not happen until the next legislative session. And there has been some reluctance by our legislators to take advantage of ARPA funding. So we'll kind of see how that goes. If it is approved, then we'll have access to that funding. If not, we simply will not. That will not occur. So more to come on that. We also discussed it as directors, the Luma software change that's happening within our health districts. That particular software would change the software we use for fiscal management as well as human resource and payroll management. That is a significant change in the state of Idaho. From all we can tell, it will be a positive change, a more efficient change in managing our finances as well as HR. They're hopeful that coming from the state controller's office and Brandon Wolf, he attended our meeting, that financial transaction or change will happen, will happen January 1, with the HR following 2 to 3 months later. So there's been a lot of discussion, a lot of preparation for that transition. That will be significant, not just for the health districts, but all state agencies will be affected by that. Wanted to talk a little bit about our Break the Silence Walk. Just to keep you aware, you have a little card in front of you. This is our annual fundraiser for suicide prevention, and you have a flyer under tab 5. You have the ability to register using the QR code. This is a large event that Panhandle Health District puts on. We haven't the last couple of years due to the pandemic. It is this year. The last one we had over 500 people in attendance. This happens at Riverstone Park in Coeur d'Alene. So invite you to take a look at that. Would love to have the attendance, or even take this flyer and distribute to others who might want to attend. Finally, I would actually 2 more items. Just remind you regarding the PhD email address. As you recall, when we discussed this before, for security reasons, we encourage all of the board members to take advantage of this email address rather than using a personal email address for correspondence. As of today, any future correspondence we send to you will come via the PhD email address. So I want to encourage your use of that. Also under tab 5 is a contact list. If you could just do a quick review of that to ensure that all of your information is clear and accurate. Finally, not on the agenda, and I got approval from our board chair to share this with you. Dr. McClandress, there is a primary care conference in Sandpoint, Idaho on the weekend of August 6th, and Dr. McClandress and I will be or some of the speakers for that event. I appreciate Dr. McClandress making this happen, where we will talk about, our topic is simply why pay attention to public health. And the attendees will be 400 to 500 primary care providers that will attend that event. And this is a great opportunity for Dr. McClandress and I to talk about public health to influential members of our community. And I very much appreciate Dr. McClandress giving us that opportunity. Are there any questions from the group?
The 400 or 500 primary care physicians, they're fielded from all over the country, I guess?
Primarily in Idaho and Eastern Washington, but certainly anyone could attend from what I understand.
And you have RSVPs on that?
The last time they held that event was 2 years ago, and they had nearly 500 people. So we're assuming the same would come. I'm not in charge of the event in any way, shape, or form, just a speaker.
Are the speakers, is the faculty established?
Yes, sir.
Okay.
Did I hear another voice? Okay, I would just ask this question, and sometimes the word department gets a little bit misused. And how did you use that again when you were talking about this infrastructure grant? Do you recall? The reason I ask that is because, see, Panhandle Health District is a district and we're not a department. None of the health districts are really a department of anything. We are unique health districts and not a department of anything.
That is correct, Mr. Chairman. Thank you for the clarification.
I don't know whether the user made any difference, but I do know that sometimes it does. The word district and the word department are used interchangeably. Hey,
Chairman,
yes.
your point raises, for me, because I'm new, again, I'm just trying to understand what this entity is. And so your point raises this. So are the health districts, they're not strictly a subdivision of state government?
No.
They have a legal status that is distinct from the state. Is that what I'm hearing you say?
Pretty much.
Okay.
Yes.
But they get their authorization from the state.
And that's where sometimes the questions start arising. You see, we have the Idaho Department of Health and Welfare.
Right.
That is a state department.
Right.
But Panhandle Health District is a unique district all of its own.
So I guess my question to you would be, what latitude do the districts have that is not that is not afforded to a department? That is to say, can you do whatever you wish? I mean, I'm trying to get a feel
Yes,
for
we do
how
whatever we
can-
wish as long as the state people approve it.
Oh, okay. So there is overview.
Oh, yes.
Okay.
Yes, there is.
And they establish parameters for your behavior.
And some of that you're going to hear about a little bit more as we go through the November election. Am I getting myself in trouble?
Well, Mr. Chairman, if I may add, no, you're not, to that, is the way we're defined is that we are what's called a political subdivision. And if in your packets, you will see in Idaho Code, Title 39 will describe health districts. But it has changed a little bit, and there's been some changes in Title 39 due to House Bill 316. So the fact that we would need to get approval on everything we do from the state has changed. That approval now largely will come from our counties to help us guide us in those things. The biggest involvement the state has with this, I mean, there is still code, and this is all still a little gray with House Bill 316. But the largest is the fact that when we get grants and services, and the biggest percentages of our revenue comes from the grants that we get, the state becomes the pass-through. So let's take our Women's, Infants, and Children grant. That is a federal grant that is housed with the Department of Agriculture. And that comes through, that money is sent to the state, and then the state is the middleman, if you will, and that funding then comes to the health district. Because of the middleman, we do follow the state compliance guidelines for that contract, even though many of their guidelines come from a federal source. But the real involvement that we have with the state is the managing of these many grants, from WIC to epidemiology and everything in between. But certainly the governance of health districts with the change in House Bill 316 comes from our county commissioners.
Yes. And the county commissioner, that's a good point. I was talking to a candidate, not a county commissioner now, a candidate running for a state office, and everything went fine until he found out I was a part of the Panhandle Health District. And then that was when he got upset with me because he did not appreciate the Panhandle Health District having authority over septic issues. He thought that
Who should be?
nobody.
Well, that's ridiculous.
Well, of course it is. Of course it is. And this is what I explained to him. If everyone did the right thing without any supervision from our ER department downstairs, that would be fine. But people don't always make the right decisions on their own without some help from outside. And I explained to him, he told me where he lived. And I said, that area of our county is exactly where we have a lot of problems of people wanting to be on the mountaintop and just let the sewage run down and take its course till it gets to the St. Mary's River.
Well, it's even worse than that. I don't know about your county, but in Bonner County, we have people that have say an R10 or an R20, and they've turned their property into an RV park. And they collect rent, and there's no regard for disposal of the sewage from the fifth wheel.
Yeah, and see,
And that's unacceptable.
and that's why counties are not supposed to issue a building permit for a dwelling, a private dwelling, until they have an approved septic plan that's signed off by the health district. So, and yet I know of places where people can sidestep the law. You see, we'd like it if every company who makes septic tanks and sold a septic tank had to report to the health district that they just sold a septic tank to Joe up the road. But you can go buy a septic tank and install it without even the health district knowing about it. Now, it'd be fine if they knew how to do it so it met code, but that doesn't happen. That's why they want to avoid us, because they want to cut corners.
Did this fellow win his primary?
Yes. Oh, he won the,
He won his primary?
yes,
Okay. Well, stay tuned.
that's right. Enough of that. Enough of that. Hey, folks, is there any other business to come before this board at this time? Anything we've overlooked? Thank you, Glenn, for tuning in. And with that, we are adjourned until September 22nd. Thank you.
Thank you, Mr. Chairman.
Recording